सलामकुम डॉक्टर साहिबा, क्या हाल है?
Assalamualaikum, how are you?
आई एम डूइंग ग्रेट। आप सुनाए, खैरियत से हैं?
मैं ठीक हूँ.
Why, I've got some issue in my camera, so I'm right now fixing it.
You are expert in this.
Thank you. I think अम्मी जो है वो ज्यादा, she's more expert in this, so she's trying to manage my camera and something like this. So it's going to take a time. टेस्ट करना है, आप टेस्ट कर लें अपनी स्लाइड्स।
स्लाइड्स तो कोई है नहीं है, वो है वीडियोस हैं, उसको करें.
हाँ जी, मेरा ख्याल है तो मैं करके देख ली, क्या ख्याल है?
देख लेते हैं. मैं करूँ स्क्रीन शेयर.
हाँ जी, स्क्रीन शेयर करके देख लें, आपके मैंने पोस्ट किया हुआ है। कर रहा है। हम्म।
ये है. सो
I think you should play it also so that we can see, we can hear it also। क्या ख्याल है, आप एक बार ट्राई कर लें?
बिल्कुल.
जी, क्योंकि ये ना हर एक को थोड़ा थोड़ा सा इशू मैंने देखा है आ जाता है।
Assalamu alaikum. Typically, aortic arch has three branches.
So is it visible?
Is it, it's both visible and also we can hear it। I guess it's we are good to go।
अच्छा, एक और है कि हम इसको अगर इधर ही कर रहे हैं एंड कैन यू सी दी स्लाइड्स.
Yes, we can see this slide also। ये तो डन हो गया।
Okay, so we keep it here and then we go back to the. हम पिछले पे ही चले जाते हैं.
पिछले पे चले जाए आप, ठीक है। यानी कि आप कह रहे हैं कि एक आध आप स्लाइड दिखा दें पावर पॉइंट के
हाँ.
बाद फिर वीडियो प्ले की जाए। ठीक है, ये भी सही है, ये भी ठीक है।
इसमें ये मेरा जो ख्याल है, आई डोंट नो वेदर आई वुड बी एबल टू रन इट और नॉट, के देर आर मेनी वीडियोस ऑफ ईच आर्टरी, सो आफ्टर एवरी वीडियो वी कैन शो एक आध, मैंने ना जो
जी जी।
मतलब द इम्पोर्टेंट पॉइंट्स which need to be, you know, remembered,
बिल्कुल।
you know. So
एग्जैक्टली।
I made like 10, 12 slides of very important points just to highlight them.
आई बिलीव, आई थिंक दोज आर वेरी इंपॉर्टेंट। बिल्कुल आप सही कह रही हैं, क्योंकि वो एक जो वीडियो मैंने भी देखी थी ग्रुप में, मुझे वही लगा कि बहुत बेसिक है। तो मैंने बल्कि ये कहा, मैंने कहा कि डॉक्टर साइमा जो है वो तो इसमें से ऑब्वियसली जो खास तौर पे क्लिनिकल पॉइंट ऑफ व्यू से है ना, वो बिल्कुल आपने बिल्कुल सही है, वो आप ऐड करें बिल्कुल।
नहीं, वो बेसिक ही अभी मैंने किया है, बट इन द नेक्स्ट सेशन आई थिंक ऑन द नेक्स्ट संडे when we will be seeing the steps of the angiography, then we can talk more about it, but I think this is basic, so we keep it basic, but still there are, you know, one or two points we can add. So
एग्जैक्टली।
we go back to our video once again and then we run the video and then we come back to this, you know, slide, and then I don't know, is it feasible or not, but I made it like this.
इट्स इजी। आप उसको बस सिर्फ ये करें कि अपना जो पावर पॉइंट है ना, उसको फिर आप ऑफ कर दीजिएगा ना। उसके बाद आप दूसरी प्ले कर दीजिएगा, तो वो आपको स्विच तो करना पड़ेगा लेकिन हो जाएगा। यानी कि पॉसिबल तो हो जाएगा। आप इसको पहले स्लाइड सिखा देना ये, और उसके बाद फिर आप उसमें स्विच कर जाए, जहां जहां पे आपको जरूरत हो ना, वो वाली स्लाइड आप दिखा दें और फिर आप स्विच कर जाए वीडियो पे।
ठीक है
बिल्कुल
अभी.
स्क्रीन शेयर। बिल्कुल ऐसे ही, बिल्कुल ये हो रहा है ना इस तरह से, तो ये सही हो जाएगा। बल्कि मैं तो ये कह रही थी कि आप के साथ मेरा ख्याल है कि एंजियोग्राफी की भी, क्योंकि मैंने जो देखी वो एनाटॉमिकल वीडियो, वो ज्यादा एनाटमी की वीडियो लगी, साथ साथ बल्कि एंजियोग्राफी भी दिखानी चाहिए थी ताकि जरा इजी हो जाए पढ़ना, जिस तरह ट्रेनिंग्स हैं उनके लिए थोड़ा बहुत उसका भी टच कर लेना चाहिए था। आपने शायद आपने देखा ही होगा।
हाँ नहीं, आई वेंट थ्रू दिस कोर्स, मैंने आज इसको देखा है। और
जी जी।
मैंने अकॉर्डिंगली जो है कोई मतलब के बेसिक सा मतलब डीएसए की जो एक आध इमेज है वही स्लाइड में रखा है। लेकिन हम
ठीक है।
नेक्स्ट टाइम जो नेक्स्ट है उसके अंदर जो है वो सारी की सारी एनजीओ करेंगे। लेकिन
सही हो गया।
इसके वो मतलब वेरी वेरी बेसिक लाइक द
ठीक
सेगमेंट्स,
है।
बट दैट वुड बी
हम्म।
एंजियोग्राफिक ऑब्वियसली।
एग्जैक्टली, हाँ एग्जैक्टली, क्योंकि उसी का से जो बेसिक आइडिया है वो ये हैंड इन हैंड ही होता है। पहले आप एनाटमी जो है वो क्लियर कर दें और कॉन्सेप्ट क्लैरिफाई करके तो फिर आप एंजियो पढ़ा दें तो काफी सही हो जाता है इंशाल्लाह। आई बिलीव कि अच्छा हो जाएगा। तो ये वाला आज का तो मेरा ख्याल है सिर्फ ये सेरेब्रल एंजियो के, और नेक्स्ट टाइम में आपने प्रोसीजर का भी बताना है ना।
We have divided it into two parts. The second part is about the venous anatomy and about the steps of the angiography. So
स्टेप्स
the
समझो।
steps that would be more clinical because I think we will be talking about the different kind of catheters used for the basic angiography and few techniques and about the views also, which is
ये
important. In the basic angio, these things are important. Then and then how to inject, how to remove the bubble from the catheter, and what should be the direction of the catheter, what should be the the direction of injection. This is all these things are important. How to navigate the wire, like the wire should be ahead of catheter, and all these small important maneuvers, but
important,
they're very very important.
important
So
practical points, yeah, exactly, ये I guess that will be very valuable. So I guess we've got 6 minutes to go.
yeah,
um, लेकिन I can't see many people have yet joined us.
but I think we will start in time.
Exactly, we will start in time because people can just also see the see the recording if they are not able to join.
Um,
लाइव स्ट्रीम तो मैंने यूट्यूब पे भी किया है। ब्रीफ से आपका इंट्रोडक्शन जो है वो मैं देखे तो फिर इसको मेरा ख्याल है स्टार्ट कर देते हैं।
बिल्कुल ठीक है, क्योंकि वीडियोस जो हैं इटसेल्फ ही 48 मिनट्स जो हैं, दीज आर द वीडियोस। एंड यू नो एंड स्विचिंग ऑन एंड ऑफ बिटवीन द वीडियोस एंड देन द प्रेजेंटेशन, उसका मैंने जो है हाफ एन आवर रखा है। तो आई थिंक ये पूरा वो मतलब इसको अगर करना है तो वी नीड टू बी इन टाइम, क्योंकि
एग्जैक्टली, इट विल बी लाइक 1.5 hours।
इट शुड नॉट बी मोर देन 1.5 आवर। उससे ज्यादा तो हो नहीं सकता तो
एग्जैक्टली, बट आई बिलीव वैसे बिल्कुल की बात सही है। मैंने इसी डॉक्टर इकबाल को भी मैसेज कर दिया हुआ है, मैंने कहा कि जूम तो ओपन हो गया है तो ऑलमोस्ट तो आप बस स्टार्ट करें।
Uh, I don't know what about the other sessions. I mean, they are having these videos and lectures like for the past 1 month, and they have some classroom जिसमें ये सारा कुछ हो रहा होता है, लेकिन मैंने देखा नहीं है तो I don't know। मुझे लग तो रहा होता है कि बड़ा कोई अच्छा किस्म का जा रहा है, but I don't know।
मुझे
they are
जी जी।
preparing it, for some time now।
Exactly, for the preparatory, pre-course preparation, they named it. So when I saw it, they what they asked me was to arrange all those line lectures on Zoom. So I thought they might be like the usual lecture. I didn't know about the videos, but I thought that these are the live lectures. मेरा ख्याल है कि कुछ जो lectures है ना, जिस तरह कुछ उन्होंने कुछ दरमियान में एक आधा लेक्चर जो कि लाइव है probably, जो कि यानी कि जिसमें वीडियोस नहीं है, यानी कि नॉर्मल लेक्चर है। तो आई एम नॉट श्योर वैसे कि क्या
नहीं, वो
हिसाब से
बाकी
है।
के जो लेक्चर्स हैं दे आर वेरी गुड लेक्चर्स जो फॉरेन फैकल्टी के हैं। दे आर आई थिंक दे आर लाइव लेक्चर्स, ओनली दीज आर वीडियोस।
वीडियोस
आई एम जस्ट
वैसे
मोटिवेटेड।
it's good also कि even if you show the videos and give an some little explanation and clarify the concept, I think it's also fine, especially for the trainees, because
This
I've
is
seen many.
important, yeah, because they can ask questions and they can anything which came into their mind they can ask right there। और जो है तो वैसे वो खुद भी रन करके देख सकते थे, लेकिन इट्स गुड कि ये एक मतलब कंबाइंड एक एक्टिविटी हो जाएगी। तो
मेंटोर्ड होगी कि जाहिर है कि कोई वो ट्रेन करने के लिए वो ज्यादा एक अच्छी ऑप्शन है।
वो ये एक आध बंदा कर देता है। आई थिंक आई थिंक अब शुरू करें।
आई गेस। तो मैं फिर ब्रीफ सबको इंट्रोडक्शन दे देती हूँ, अब तो हम पूरी वो कर लेते हैं जिस तरह से भी है ना। सो आई गेस कि पीपल विल कीप ऑन ज्वाइनिंग और watch it live on YouTube etc. So just let me give a very brief introduction of you and also the of the NASSIC series. Just a little moment. So I guess we have got some. One acid side. Okay, so everyone, good morning, good evening, or good afternoon, wherever in the world you are right now. I'm pleased to host this program on the behalf of the Neuroendovascular and Stroke Surgery International course called the NASSIC, which is being arranged in collaboration with the Pakistan Society of Neurosurgeons and the Nishtar Medical University, as well as the Children Hospital Complex Multan, and obviously the Nishtar Hospital, and yours truly, News. So it's a very good collaboration, and I'm happy to promote and to assist in this very amazing and I hope very insightful course for you. And our today's lecture, it is it's the second module and the first lecture of the second module, and I'm happy to introduce Dr. Saima Ahmed. She's a female neurointerventionist from Pakistan with a very good and impeccable experience in all the neurointervention, and she has presented at various international and national platforms and has conducted so many workshops. So I'm very happy and pleased to welcome her here. I had the honor of working with her during our time together at PINS, Punjab Institute of Neurosciences. So it's a real pleasure to welcome you, Dr. Saima Ahmed, here today for this new lecture for which we are really excited.
Thank you very much, Noor, for this kind introduction, and I'm so happy to be here with you all. First of all, many congrats to Dr. Iqbal Kharal for conducting this wonderful educational activity. It will be a breakthrough, inshallah. So, today, as Dr. Noor-ul-Huda has mentioned that this is the session one of the module two, in which we will be talking about the cerebral angiography, and only the arterial system we will be talking about today. And the next part of this activity will be next Sunday, in which we will talk about the venous anatomy, as well as we will be talking about the steps of the angiography. So, as you all know that basically, we are more concerned with the cerebrovascular angiographic anatomy. So we try to, integrate the angiography in between these videos, just to, highlight the importance of the angiography. And what I think is this, that when you see the textbooks, you can easily identify the all kind of the vessels, but it's not easy. When you see them live, you cannot identify. So I think that every neurosurgical, the trainee must be knowing all the angiographic details and must be able to, read the angiogram, cerebral angiogram, because that's important. So that would be a didactic one. We try to be didactic, and anytime you can unmute yourself and you can ask any questions, and we are here to answer you. So the agenda of this session is this, that we will be running videos. And after the end of each video, there will be a pause in which you can ask the questions if you have any questions. And if you don't have any question, then we will move to the next video. So we start our program. So here is the first video of the course, and let me run this. So please let me know everybody seeing my screen and also hear me.
I believe that we are good to go.
Okay,
I
so I
think
Assalamu alaikum. Typically, aortic arch has three branches. Brachiocephalic trunk or innominate artery, which divides into right common carotid artery and right subclavian artery. The second branch is left common carotid artery, and the third branch is left subclavian artery. Vertebral arteries arise from the right and left subclavian arteries. Variants of aortic arch are divided into common and less common variants. The common variants are three. The first common variant is a bovine arch, which has two types. In the first type, there is a common origin of the innominate artery and the left common carotid artery. In the second type of bovine arch, the left common carotid artery arises from the innominate artery. So they have either a common origin or the left common carotid artery arises from innominate artery. The second common variant is apparent right subclavian artery, in which the right subclavian artery arises from the left side of the arch. And in this variant, there is a separate origin for each of the three major vessels, the right and left common carotid arteries, and the left subclavian artery. The last of the common variants is the origin of the left vertebral artery from the aortic arch instead of the regular origin from the left subclavian artery. The less common variants of the aortic arch are five. The first one is the double aortic arch. And the major vessels arise on each side from each of the aortic arches. The second variant is double aortic arch with atresia of one of these arches, and the major vessels arise from one arch only. The third, less common variant is the right aortic arch with mirror configuration. The innominate artery is on the left side, carotid and subclavian artery. The fourth variant is right aortic arch with non-mirror configuration, right subclavian artery, right common carotid, left common carotid, and left subclavian artery. In this case, this left subclavian artery is apparent, And the last less common variant is by innominate artery. Innominate artery on the right side dividing into subclavian and common carotid, and innominate artery on the left dividing into common carotid and subclavian arteries. As a result of aging and atherosclerosis, the major vessels become elongated and tortuous. This is a classic arch, and this is the arch which we see frequently in elderly patients and patients with chronic hypertension. You will see the origins of the major vessels arising proximally with sharp angles like this. This is the innominate dividing into subclavian and common carotid, then the left common carotid artery origin, and finally the left subclavian artery. The burn or vertebral catheter is usually sufficient to cannulate the ostia of major vessels in this typical or classic arch, while in this arch we usually use SIM2 or Simmons type 2 catheter. The double curves of this catheter allows cannulation of these vessels.
So, any question after this video?
I cannot see any question in the chat box. I believe that if somebody has any question, please share in the chat box or raise your hand so we can unmute you. Please. Somebody is asking.
Yeah,
Can you
no,
please can you please summarize it? Dr. Khadija Tahira is asking, can you please summarize it?
okay. So I will summarize it. And the thing is that we do not need, another pictorial essay of these aortic arch types, because we go through these essays once again, and then you forget everything. So I have this picture for you. This is a very basic picture. You need not to memorize all the things. You need to memorize the basic things and which you come across in your daily life. And these are the variants which you come across while doing the angiography. So this is the classical type. Here you can see that we have the right brachiocephalic trunk, and then left common carotid artery, and then this is left subclavian, and from the left subclavian we have left vertebral artery. So this is the classical type. And then this is the bovine arch. The next common variant is the bovine arch, which occurs into like 3 to 25% of the cases. And you come across this arch very, very oftenly during angiography. In this type, you can see that, can you see my cursor here? So you can see that from the right brachiocephalic trunk, the left common carotid artery is arising from the same trunk, from the right side, either from the same trunk or from the root sometimes. So we have this common origin of the left common carotid and the right brachiocephalic trunk. The right brachiocephalic trunk divides into right common carotid and then the right subclavian. And here you can see from the left subclavian, we have left vertebral artery. So the bovine arch, this is the called bovine arch, which is a very common variant, and you come across this very, very oftenly. And when you come across this, you have to use different type of the catheters for the angiography, which we will discuss in our next lecture. So the third variant is, this is the direct vertebral artery arising from the left aortic arch. You can see it's not arising from the subclavian artery, but it's arising directly from this aortic arch. And then we have the second variant, in which you have direct origin of the vertebral artery from the aortic arch, and then you have bovine type on the other hand. The left common carotid artery is arising from the right brachiocephalic trunk, and left vertebral artery is arising directly from the aortic arch. So I think these are the common variants, and you must have this in your angiography suite so that you can, see it more oftenly, and then you try to memorize it whenever you come across this. This is important. So this is again the angiographic view of the classical picture of aortic arch. This is brachiocephalic trunk. On the right side, from the brachiocephalic trunk, we have right common carotid, we have right subclavian. And then this is the left common carotid artery, which is arising directly from the aortic arch. And then we have left subclavian, and then this is left vertebral arising from the left subclavian. So this is classical type of the aortic arch. And then you can see that this is the diagnostic catheter here. So the next, this one I have found, so I just try to show you that this is one of the variant we have just seen, that this is direct origin of the left vertebral artery from this left side of the aortic arch, and you can see here this is right brachiocephalic trunk divided into the right common carotid and then into the right subclavian. Then we have this left common carotid arising directly from here, and then we have this left vertebral artery, which is arising directly from the aortic arch, not from the subclavian. And then this is left subclavian. So this is one of the variant. And so another thing which is very, very important here is this, that aortic arch is most commonly affected by the atherosclerosis, but we do not see these changes normally during the angiography. The things which we normally encounter during the angiography is the changes which we occur during the old age. So there is elongation of the supra-aortic arch in the old age. You see, this is the aortic arch. This is elongation of the aortic arch, and then you see that how difficult to navigate these vessels. So whenever you are anticipating, whenever you are going to do angiography on in old age person, you must anticipate all these difficult kind of the vessels. You see here that how difficult is to navigate through this one and then through this one. So this is again the brachiocephalic. This is brachiocephalic. It is divided into the right subclavian, then into the right common carotid, and here this is sorry, I have to admit in between. So this is the left common carotid, and here you can see this is left subclavian. So we have to have a different kind of the catheter with us when we are doing the angiography in the old age people. So we will discuss those catheters. So with this.
Very much. One more thing that I want to say, Dr. Saima, please take your time and attention, because I will look after all those people who are in the waiting area. So please
Okay.
don't
Thank you.
don't take any. And I also want to add, I think because the bovine arch is one of the most common variants, I think there are two other things that we need to consider. It is like one of them is the true bovine arch, and the other is the truncus bicaroticus.
Yes,
Let me tell one.
I'm not talking about these things because as we have
Going to-
talked earlier, that this is very basic. So I will talk about these complicated things in the next session. So I just
Exactly.
want to introduce the students with the basic, four branches of the aortic arch.
Yeah,
In this.
exactly.
So
So,
so so we go to the next part here. Let me.
Origins of common carotid and subclavian arteries are similar. On the right side, common carotid and subclavian arteries arise brachiocephalic trunk or innominate artery, while on the left side they arise by separate origins directly from the aortic arch. Subclavian arteries course to the upper limbs while carotid arteries course cranially in the carotid sheath with the internal jugular vein and 10th cranial nerve. Common carotid artery has no branches, except for some variations, where the proximal branches of external carotid artery arise from the common carotid artery, while subclavian artery has many branches. Subclavian artery exits the thorax via the superior thoracic aperture between anterior and middle scalene muscles, and then between first rib and clavicle. At the lateral border of first rib, it continues as the axillary artery. Subclavian artery can be divided into 3 segments or 3 parts according to its relation to scalenus anterior muscle, where the first segment lies medial, the second segment lies posterior, and the third lies lateral to scalenus anterior muscle. The first part of subclavian artery has 3 branches, which are the vertebral artery, the internal thoracic or internal mammary artery, and the thyrocervical trunk. The second part has 1 branch only, which is the costocervical trunk. And the third part has also 1 branch, which is the dorsal scapular artery. Branches of subclavian artery can be grouped into the mnemonic vitamins C and D. V stands for vertebral artery, I for internal thoracic or internal mammary artery, and T for thyrocervical trunk. Vitamins C and D. C stands for costocervical trunk and D for dorsal scapular artery.
So we have any question here? Anybody can ask any question.
Don't seem to have any question in the chat box. I think we can wait for a couple of minutes so that if anybody has any question, please type in the chat box or raise your hand so we can unmute you.
Okay, so there are few points which I would like to mention about the subclavian artery and the common carotid artery. So the things which are important here is this, that the subclavian artery, it has the important, we talk about only the important branches of the subclavian artery. So subclavian artery give rise to the different trunks. This is the first trunk, which is the thyrocervical trunk, and this is the second trunk, which is the costocervical trunk. And then this downward is artery. This is internal thoracic or internal mammary artery, and this is the vertebral artery. So these are the branches of the subclavian artery. So and this is left vertebral angiogram. You can see the tip of the catheter here. You can see the tip of the catheter here. So this is the left vertebral angiogram, and this is the vertebral artery. So the way I remember these, the trunks is there because the thyroid gland is in the middle. So I always remember that thyrocervical trunk comes first and then the costocervical trunk, because thyroid is in the middle. So that's my way to memorize these trunks. And there are further the different branches of the thyrocervical and the costocervical trunk, but I tell you, in the next slide, that which branches are important. So I go back to the similar one and then I tell you. So the thyrocervical trunk, the most important branch of the thyrocervical trunk is the ascending cervical artery. And the most important branch of the costocervical trunk is the deep cervical artery. You need not to memorize all other arteries, because why these arteries are important, the ascending cervical and the deep cervical arteries, because vertebral artery, ascending cervical, deep cervical artery, and anterior spinal artery, all of them are interconnected together through collaterals. So this is very important. They not only supply the muscles of the occipital region and the neck region, but they are also supplying the neural, components, as well as they are supplying the vertebra. So it is very important. And this I found in, in some of the, at some site, and I liked it so much. You can see here, this is ascending cervical artery, which is again the branch of the thoracocervical trunk. And here you can see that this is the deep cervical artery, which is the branch of the costocervical trunk. So I repeat it again and again so that you memorize it later on. So again, this is, what is this? This is right vertebral angiogram. This is right side, and you can see this is right vertebral artery, and this is right subclavian artery. So here you can see the tip of the catheter. So this is right vertebral angiogram. And in the right vertebral angiogram, you can see that this is the deep cervical artery. Deep cervical artery is the branch of the costocervical trunk. And this is internal thoracic, internal memory artery. So these branches, there are other branches also like subscapular artery, but that's not important. The important branches are these because they are in, they form the anastomosis with the vertebral artery. Again, this is the same, which I told you, in which you can see that this is ascending cervical, and then this is the deep cervical. And this is the vertebral artery running through the foramen transversarium. So, and this is the carotid bifurcation. It's a common carotid artery. It is bifurcating at the level of the C4. This is again, this is subtracted view, and this is unsubtracted view. This is subtracted view because it is not showing any kind of the bones. And a digital subtraction angiogram is called digital subtraction angiogram because it subtracts all the bones. And this is without subtraction. And you can see here that here is the tip of the catheter. This is on the left side, and this is deep cervical artery. So just to show you that how this artery looks like. It's very easy once you start doing the angiography, that then you will memorize it very, very easily. So as I told you earlier that why these vessels are important. These vessels are important because they form the collateral anastomosis with the vertebral artery. So here you can see this is unsubtracted and this is subtracted. This is again unsubtracted with the bones and vertebra. And this is subtracted, in which the bones are subtracted. And you can see that this is the right vertebral angiogram. This is the tip of the catheter. This is vertebral catheter. And you can see that this is the right subclavian artery and this is the right vertebral artery. And this is right vertebral angiogram. And through the right vertebral angiogram, you can see that all the vessels are highlighting. Like this is the branch, which is ascending cervical artery. This is deep cervical artery. And here, this is anterior spinal artery. So why I am highlighting these vessels here? Because whenever you are doing any kind of the neuroendovascular procedure in the neck, and you must be aware of these anastomoses. Because if you are doing any kind of the embolization, you can introduce the particles or some embolic agent into the vertebral artery if you are not aware of these anastomoses. So these are the few points which I wanted to highlight regarding the subclavian artery. And one more point. So in the previous video, you can see they have talked about the common carotid artery and also the subclavian artery. But there is only one point I would like to add up here, which is the level of the bifurcation of the common carotid artery. The common carotid artery bifurcate at the common level, which where it bifurcates is the C3, C4. This is the commonest. It has many variations. It can bifurcate from the C2 or even from the C1 from the C2 to the T1. but this is the commonest, level of the bifurcation. Here you can see again, it's the lower border of the C4. So here it can be divided like this. So I think we go back to our videos again, once again. Sorry, this is not... So we run our course once again.
This segment ascends cranially in the carotid sheath with the internal jugular vein and 10th and 11th cranial nerves. Classically, this segment has no branches, except for some variations where proximal branches of external carotid artery may arise from internal carotid artery, like ascending pharyngeal artery. The second segment is the petrous segment, which extends from the carotid canal of petrous bone till the posterior margin of foramen lacerum. This is the posterior margin of foramen lacerum. This is the petrous segment. This segment has two parts, a vertical part here and a horizontal part, which courses anteromedially like this. The vertical part is about 1 centimeter in length, and the horizontal part is about 2 centimeters in length. This segment has three branches: a preosteal branch, which arises at the carotid canal of petrous bone, a caroticotympanic branch, and a mandibulovidian trunk, which divides into mandibular artery and the vidian artery. The third segment is the lacerum segment. This small part from the posterior margin of foramen lacerum till the petrolingual ligament, which extends from the petrous apex to the lingula of sphenoid bone. The lingula is medial to the foramen ovale. This is the foramen ovale and foramen spinosum. This is the lingula, and this is the petrous apex. Here is the petrolingual ligament. So the lacerum segment extends from the posterior margin of foramen lacerum to petrolingual ligament. This segment has no branches, but the mandibulovidian trunk may arise from this segment instead of the petrous segment. The fourth segment is the cavernous segment, which is S-shaped. It has two vertical parts and one horizontal part, which is the longest part. This segment forms the greater part of the carotid siphon, and it is located lateral to the body of sphenoid bone in the carotid sulcus. This segment has three branches, which are the meningohypophyseal trunk, infrolateral trunk, and capsular arteries of McConnell to the pituitary gland. The fifth segment is the clinoid segment, which extends between the proximal and the distal dural rings. This part is a small wedge-shaped part and has no branches. The anterior clinoid process lies superior-laterally to this small part. The clinoid segment can be named the interdural segment, and above it is the intradural segment, which courses both superiorly and is divided into two segments. The proximal one is the ophthalmic segment, where the ophthalmic artery arises from the internal carotid artery and goes into the orbit through the optic canal with the optic nerve. This segment has three branches: ophthalmic artery, superior hypophyseal arteries, and perforating arteries. And finally, the communicating segment, from which arises the posterior communicating artery, the anterior choroidal artery, and the perforating arteries. Each of these segments, the ophthalmic and the communicating, is about 1 centimeter in length. So the smallest segments of ICA are the clinoid and lacerum segments, and the lines ICA segments, cervical segment from common carotid artery bifurcation to carotid canal of petrous bone, petrous segment from carotid canal of petrous bone to posterior edge of foramen lacerum, petrolingual ligament, cavernous segment from petrolingual ligament to proximal dural ring, clinoid segment between proximal and distal dural rings, ophthalmic segment, and finally communicating segment. Each ICA segment has either three or no branches. So the cervical, lacerum, and the clinoid segments has no branches, and the petrous, cavernous, ophthalmic, and the communicating segments, each of these segments has three branches. R for rostrum.
So, what we have in our chat box,
So far, I cannot see any question in the chat box, but I'm looking for it. If there is any question that hops in. Is there any question? Please share it in the chat box, or you can raise your hand so that we can unmute you.
so well, in that case, just to recap, because he was telling everything in a very, hasty manner. So, the internal carotid artery anatomy, endovascular anatomy, is according to the bony landmarks, you see. But since this is digital subtraction angiograms, and we have subtracted the bones here, so we imagine, that where would be each segment starts and where the segment ends. So this is the lateral common carotid angiogram. Why it is common carotid angiograms? Because you see the branches of the external carotid artery as well as internal carotid artery in this lateral angiogram. If we have only internal carotid artery, then it would be the selective internal carotid artery angiogram. So whenever somebody asks you that what type of injection is this, it's left common carotid artery angiogram, and it is lateral. And why you can, how you can say this is lateral? You have to see the bony landmarks. It's not clear here, but one can see the orbit here. You can see a very subtle kind of, orbital line you can see here. And you can also see the nasal bone, but here it is not visualized. I'll show you, in the next one. So as he has already mentioned that endovascularly it is divided into 7 segments, but we need not to memorize these, tedious details of all the segments. The common artery formation, which is of the C4, the internal carotid artery runs up to the level of skull base. This is the skull base, and this is the cervical. The cervical part of the internal carotid artery, some branches, but it's too early to tell you about the variants. So there are no branches of the internal carotid artery in the cervical part. So this is the skull base. We have to imagine that this is the skull base and this is the petrous part. It runs into the petrous bone. Here, this is the petrous bone. So it divides into the 2 parts. The first is the vertical part, and then there is the horizontal part. So it runs in the picture. I'm not going to tell you just now because we are focusing on main segment. And the next is the lacerum. This is the lacerum segment. It exits from the petrous part and then come out through the lacerum, foramen lacerum. And this is a very small segment. And then the next is this sinus part. It runs into the cavernous sinus. And here you can see it is very beautiful outlined here. This is the cavernous part. It runs into the cavernous sinus. And small part, which is the anterior clinoid, from where it lies close to the anterior clinoid process, which just now the presenter has shown you in the video. And then it curved and becomes intradural. So the first intradural, the branch which comes after piercing the dura is the ophthalmic artery, and hence it is called para-ophthalmic segment or ophthalmic segment or whatever you call it. So here, this is ophthalmic artery. So the first artery, which is intradural, is ophthalmic artery. And by intradural, we means that if any of the aneurysm happens to be here and it ruptures, we have subarachnoid hemorrhage. And if any of the aneurysm lies into the cavernous segment and that ruptures, we does not have any subarachnoid hemorrhage because that's extradural. And after this ophthalmic segment, which is the first intradural segment, we have the last segment, which is the posterior communicating segment, and this large branch is again the posterior communicating artery, and another very small artery lies above here, which is the anterior choroidal artery. You have to see always and always it exists like this, sometimes small and sometimes big, and here it is anterior choroidal artery. And then here lies the carotid terminus, and the two terminal branches are the MCA and the anterior cerebral arteries. So these are the basic, the segments with their bony landmarks. Few other, these are not my pictures actually, but I have obtained them from the Google because they are showing these segments very, very beautifully. And these are the AP projections, and these are the lateral projections. And this is the right internal carotid artery angiogram, and this is the lateral right internal carotid artery angiograms. As I have mentioned earlier, because you do not see any of the external carotid artery branches, so this is internal carotid artery angiogram. It is not common. And this is unsubtracted. This is again unsubtracted, and you can see the bony landmark here. Now, many of the times I happen to be asked by the questions that how do we know that it is the AP projection and the lateral projection? So here you can see that this is the nose here. These are the orbits here. So you can imagine that this is AP projection. And here you can see that this is the lateral projection because you can see this is the nasal bone here. Again, just to, show you some of the very beautiful, angiographic views, once again, all lateral. So on the lateral projection, you can see that this is the first branch, which is ophthalmic artery, and then the posterior communicating artery. So we go back to our video once again. Sorry. So let's go through this. So now the anterior cerebral artery.
Before we get into the segments and the branches of anterior cerebral artery or ACA, it's better to have a look at the parts of corpus callosum. Parts of corpus callosum can be remembered by this mnemonic. Remember G before S. R for rostrum, G for geno, B for body, and S for splenium. Parts of anterior cerebral artery or ACA. ACA has 5 segments from A1 to A5. A1 is a peri-communicating or horizontal segment. The segment extends from the origin of ACA, from internal carotid artery or ICA, till anterior communicating artery or ACOM. This segment cannot be appreciated in the lateral view. It is better appreciated in the AB view. A2 segment extends from anterior communicating artery till emergence of the callosomarginal artery or the gene of corpus callosum. This is the callosomarginal artery, and this is A2. A2 segment can be called the infracallosal segment. A3 extends from the genu to 3 centimeters posterior to the genu and can be called the precallosal segment. A4 is the supracallosal segment, extends from 3 centimeters posterior to the genu till the terminal segment. And A5 is the terminal segment. And the termination of anterior cerebral artery is the posterior pericallosal artery or splenial artery, which anastomosis with the posterior pericallosal artery, which is a branch of the posterior cerebral artery or PCA. So the 5 segments of anterior cerebral artery are A1 pre-communicant, A2 post-communicating callosal, A5 terminal segment. Anterior cerebral operating arteries, anterior communication. A1
Dr.
segment
Simon?
also gives
Okay, yes.
connects the two anterior cerebral arteries together and is also best appreciated in the AB view and not in the lateral view. A2 segment gives medial orbitofrontal artery because the lateral one arises from the middle cerebral artery, frontopolar artery. Callosomarginal artery gives the 4 cortical branches, anterior, middle, and posterior internal frontal arteries. Tree also gives cortical branches, mainly superior and inferior internal parietal arteries and posterior pericallosal artery. Again, anterior cerebral artery has 3 types of branches: perforator arteries from A1, A4, and A5. The second type is anterior communication type is cortical branches. These cortical branches can be remembered by this mnemonic: frontal, image prosperity, with frontal artery, F for frontopolar artery, IF for internal frontal arteries, which are anterior, middle, and posterior, P for paracentral artery, again P for parietal arteries, which are the internal parietal arteries, superior and inferior, and again P and P for posterior pericallosal artery. If you asked about the recurrent artery of Hübner and why you didn't mention, this is because recurrent is the longest straight artery, which arises from A1 segment. So it is one of this group of perforators.
I believe there is some interruption in the video. Dr. Simon, is everything okay? I
Can
believe
you
there
hear
is some.
me?
Yes, yes, we can hear you.
Ah, okay.
I think there's some internet
I think
interruption.
the connection was lost. So,
Exactly.
so did you go through? Yeah. So, did everyone listen to that anterior cerebral artery video or not?
It was like broken in the middle of the video that you have been playing. It broke up into many parts in the middle, and like there were so many interruptions over there.
So, we can go through that again, I guess.
I believe.
Okay. So, I'm going to play it once again. Okay.
Yes, I think so.
Everybody is seeing the.
Before we get into the segments and branches of anterior cerebral artery or ACA, it's better to have a look at the parts of corpus callosum. Parts of corpus callosum can be remembered by this mnemonic. Remember G before S. R for rostrum, G for geno, B for body, and S for splenium. Parts of anterior cerebral artery or ACA. ACA has 5 segments from A1 to A5. A1 is the peri-communicating or horizontal segment. The segment extends from the origin of ACA, from internal carotid artery or ICA, till anterior communicating artery or ACOM. This segment cannot be appreciated in the lateral view. It is better appreciated in the AB view. A2 segment extends from anterior communicating artery till emergence of the callosomarginal artery or the gene of corpus callosum. This is the callosomarginal artery, and this is A2. A2 segment can be called the infracallosal segment. A3 extends from the geno to 3 centimeters posterior to the geno and can be called the precallosal segment. A4 is the supracallosal segment, extends from 3 centimeters posterior to the geno till the terminal segment. And A5 is the terminal segment. And the termination of anterior cerebral artery is the posterior pericallosal artery or splenial artery, which anastomosis with the posterior pericallosal artery, which is a branch of the posterior cerebral artery or PCA. So the 5 segments of anterior cerebral artery are A1, pre-communicating or horizontal segment, A2, post-communicating or infracallosal segment, A3, precallosal segment, A4, supracallosal segment, and A5, terminal segment. Collectively, anterior cerebral artery gives 3 types of branches, which are the perforating arteries, anterior communicating artery, and cortical branches. The perforating arteries can be divided into 2 types. Medial lenticulostriate arteries, which arise from A1 or first segment of ACA, and supply basal ganglia and optic apparatus. Other perforating arteries are splenial perforators, which arise from A4 and A5 segments. A1 segment also gives anterior communicating artery, which connects the 2 anterior cerebral arteries together and is also best appreciated in the AB view and not in the lateral view. A2 segment gives medial or frontal artery because the lateral one arises from the middle cerebral artery, frontopolar artery. Callosomarginal artery gives 4 cortical branches, anterior, middle, and posterior internal frontal arteries, paracentral artery. Terminal anterior cerebral artery also gives cortical branches, mainly superior and inferior internal parietal arteries and posterior pericallosal artery. Again, anterior cerebral artery has 3 types of branches: perforator arteries from A1, A4, and A5. The second type is anterior communicating artery, and the third type is cortical branches. These cortical branches can be remembered by this mnemonic: on, frontal, imaging, find, peace, and prosperity. Peace and prosperity. O for orbit frontal, medial orbit frontal artery. F for front polar artery. IF for internal frontal arteries, which are anterior, middle, and posterior. P for paracentral artery. Again, P for parietal arteries, which are the internal parietal arteries, superior and inferior. And again, P and P for posterior pericallosal artery. If you asked about the recurrent artery of Hübner and why you didn't mention, this is because the recurrent artery of Hübner is the longest and largest medial lenticulostriate artery, which arises from A1 segment. So it is one of this group of perforators.
So everybody can see my slides.
I hope so. I believe that is there anybody who cannot see the slides?
Okay. So now we have talked about the internal carotid artery previously, and one of the two terminal branches of internal carotid artery are the anterior cerebral artery, and the other one is the middle cerebral artery. So this is a very nice diagram I have found on internet, and you can see that they have highlighted these branches in a very beautiful color. But I'm afraid that I'm not interested in these colors and these branches, because I think these are just to, just to memorize, not to memorize, but just to know that these areas are being supplied by the ACA. So basically, we should be knowing the segments and the basic supplies of the ACA. So the first branches arising from the A2 segment are the orbitofrontal, frontopolar, and then anterior frontal, middle frontal, and the posterior frontal, and then precentral and superior inferior parietal. And then this is pericallosal. Pericallosal give rise to the splenial artery, which basically communicate with the splenial branch of the posterior cerebral artery. So we need not to memorize this initially, but yeah, later on, but just to know these things. So this is the angiographic view. This is the lateral view, and I'm interested in this view because we are going to discuss the angiographic anatomy here. So this is the lateral projection of left internal carotid artery angiogram. And, the lateral angiogram is the best angiogram where you can see all the branches of the ACA. It is very difficult to see these branches in the AP projection because these branches always superimpose when you see in the AP projection. So in the lateral angiogram, the problem is this, that when the ICA terminus divides into the ACA and MCA, this is difficult for the beginners to see that which part is the ACA and which part is MCA. So if we consider this part as ICA terminus, then you can see that one branch is going in the upward direction and another branch is going in the backward direction. So the one which is going in the upward direction, that is always ACA, and the one which is going in the backward direction is the MCA. So this is something which is always confusing for the beginners, that in the lateral projection, that which part is MC and which part is ACA. Now, the A1 segment, which is the horizontal segment, and the first part, that is more best appreciated in the AP projection. That is the pre-communicating part, and that is the part which ends at where the anterior communicating artery lies. So this part, this blue part, is actually, this is the A2 segment here. And then this is the A3 segment. And from the A3 segment, as you have seen in the video, that we have a corpus callosum here. So it divides into the two big branches. The one which goes towards the corpus callosum, it is called the pericallosal branch, because it encircles the corpus callosum. And the another one which arises from here and it goes towards the margin, it is called the callosomarginal. It's corpus callosum and then it goes towards the margin. And these are the cortical branches. Now from this part, which is the A2 part, we have these two branches. The one is the frontopolar artery and another one is the orbitofrontal artery. You have already seen these branches in the previous video. So the rest of the cortical branches I have shown in the previous one, and I'm not interested in those, but you can see, and it is not visualized further, but when it comes here, like it encircles the whole of the corpus callosum, it comes up to the A5, which is the last part is the 5 segment. Here, there is the anastomosis from the splenial branch of the posterior cerebral artery, and can be appreciated. Here we go back to our videos to see them.
I believe there is some internet interruption again. I think that your internet connection is a little unstable, and it's quite it's quite normal nowadays because there are so many net glitches right now that we are facing. So right now we can only see that your window is is quite still. Yes, we can keep moving now.
So you can't hear me?
We can hear you, but from time to time, it's like your computer jams and the video stops
You
and
can't see me?
off. We can hear you, and we can also see the screen you are showing. But from time to time, it happens that there are some little interruptions. Right now, it's okay. I believe when you play it, I will let you know. Now we cannot see you. Uh, Dr. Simon, can you see us? Yes, we can see you now. But we can no longer hear you. You are muted. Dr. Simon, yes, we can.
Now can you
Yes,
hear me?
yes, we can hear you.
So we go back to our video session and I start with the middle cerebral artery. So everybody can see this?
Middle cerebral artery, or MCA, has 4 segments. Internal carotid artery, or ICA, bifurcates into anterior cerebral artery, or ACA, which is a medial terminal parallel. MCA has 4 segments. 4. M1 is the horizontal or sphenoidal segment, which XTA by 4 peninsular segment and extends. M3 is the opercular segment, and it's related to the opercular surfaces of the frontal and temporal lobes. It extends from the circular sulcus of insula till emergence of MCA from the Sylvian fissure. M4 the terminal cortical perforating arteries and cortical branches. Perforating arteries arise from M1 segment to supply basal ganglia and internal capsule. And the lateral group of lenticulostriate arteries because the medial group arises from A1 segment of anterior cerebral artery. Both groups of lenticulostriate arteries are best appreciated in the AP. Cortical branch of MCA are best appreciated in the lateral view, so let's have a look. MCA has 12 cortical branches. Cortical branches of MCA emerge anteriorly and inferiorly to supply the frontal, parietal, occipital, and temporal lobes. Frontal lobe has 4 branches.
Again, the screen seems to have jammed. I believe
Frontal artery, prefrontal lobe has 4 branches and posterior temporal arteries.
You can't.
Now it's like playing, but it's quite interrupted.
Parietal arteries. And finally, occipital artery.
I believe there are some, nowadays we are having a lot of internet issues from Pakistan. If you are in Pakistan, these issues are quite, are quite common, and you can be, expecting them. So I believe this is the same issue that everyone is facing right now in video streaming. Well, I believe that everyone knows that there are some certain issues with the internet nowadays from our part of the world. So sometimes it really happens that we cannot replay or cannot stream the video live. If you are in Pakistan, you might have you might have faced these issues yourself. So I believe that this is the same issue that's been going on right now, and the internet is a little bit of interrupted. So, Dr. Saima, can you hear us? Dr. Saima, are you with us? I think Dr. Saima has just joined in again. I'm Of course, the recording will be available. Please subscribe to my channel. Dr. Shah said, okay, let me send you the link to my YouTube. So in case you want to review it, please feel free to subscribe to my channel and to access the recording. Dr. Saima, can you hear us and can you see us? Dr. Saima, can you hear us? We can see the video being played without any, sound. Yes, you have. Dr. Saima, we can just see the video being played in the background somewhere, but we cannot hear it. And we cannot even see you as well.
Vertebral artery has many branches which can be divided into extracranial.
Now, what happened?
Extracranial include branches to
We can
stellate
see,
ganglion,
we can
mainly
see
from
it
C1,
now.
spinal from C1 to C6, spinal cord, nerve roots, and bony structures.
You can't see me?
Oh, we cannot see you, but we can see the video. Although it's a little bit of interrupted, not quite smooth, but still we can.
Like most of cerebral arteries, vertebral artery has 4 segments. V1, prevertebral or extraosseous segment, extends from the origin of vertebral artery V2, vertebral or foraminal segment, extends from the foramen transversorium of C6 to the foramen transversorium of C2. This segment runs superiorly in the vertebral canal and is surrounded by venous plexus. V3, atlantal or suboccipital segment, extends from C2 to C1. According to some authors, it extends from C2 to dura. V4 is the terminal segment from C1 to basilar artery. According to some authors, V4 is the intracranial segment. This is a model of the first and second cervical vertebrae, which are the atlas and axis. This is anterior and this is posterior. Again, vertebral artery has 4 segments. The first from subclavian artery to C6, the second from C6 to C2, the third from C2 to C1, and the fourth from C1 to basilar artery or the intracranial segment. So vertebral artery passes through the transverse foramina from C6 to C1. Above the foramen transversorium of C1, vertebral artery passes horizontally, posteriorly and medially to pass through a groove on the upper surface of the posterior arch of C1. Then it courses anterosuperiorly to join the opposite vertebral artery, forming the basilar artery very close to the pontomedullary junction.
They can't see me. म्यूट क्यों किया मुझे अनम्यूट करूं
Vertebral artery has many branches, which can be divided into extracranial and intracranial branches. Extracranial branches from proximal to distal include branches to stellate ganglion, mainly from V1,
See me.
spinal branches
Yes.
from C1 to C.
We can no longer hear anything. Rosaima, there's some issue in the sound.
Perforators, two medulla and inferior cerebellar peduncles, anterior and lateral spinal arteries. Anterior spinal arteries are bilateral. They form a median artery at the junction of C2-3, and it supplies the anterior surface of medulla and spinal cord. And the largest branch of vertebral artery is the pica, or posterior inferior cerebellar artery.
Noor, can you hear me?
Yes, we can hear you, but in the middle, the sound of the video was, muted. So I think it was working after you. I somehow, you were probably muted or something like this. We could hear you.
Okay.
It was
I
a
don't
brief
know.
moment.
There is some problem with the connection today. They are otherwise very slow. I don't know. Now, uh, now,
It's
now, what should I do? Should I go back to my slides now, or should I run the video?
I believe that you can complete the video and then go to your slides. I
Okay.
think you can complete this video, yes.
Yeah, that would be more appropriate. So, we have just seen the vertebral artery. So,
Exactly. We cannot hear you any longer. We can't hear you.
okay.
Yes. Yes, we can hear you now.
So, I have started the next video.
Origin and determination of basilar artery. Origin of basilar artery is very close to the junction between the bones and the medulla, or pontomedullary junction. It courses superiorly on the anterior surface of bones and terminates very close to the junction between midbrain and bones, or pontomesencephalic junction. It begins by the joining of the two vertebral arteries and terminates by dividing into two posterior cerebral arteries. Basilar artery gives two types of branches: perforating arteries and long circumferential arteries. Perforating arteries, or pontine branches, supply bones and midbrain, and they are divided into two types: medial, which are short arteries, about 5 millimeters in length, and circumflex, which are longer, about 15 millimeters in length. Long circumferential arteries are three pairs of arteries from inferior to superior. The anterior inferior cerebellar artery, or ICA, it arises at the junction between the lower third and upper two-thirds of basilar artery. The second is the internal auditory, or labyrinthine artery, which may arise from the ICA or directly from the basilar artery. The third one is the superior cerebellar artery, which arises very close to the termination of basilar artery. All cerebellar arteries will be discussed in a separate video. or posterior cerebral artery or PCA has 4 segments, which are named according to the sister in which they are located. P1 or pre-communicating segment extends from the basilar artery till pecom artery. It can also be called the mesencephalic, peduncular, horizontal, or basilar segment. P2 is a post-communicating segment. It extends from pecom artery till the posterior aspect of midbrain or the origin of inferior temporal arteries. It can also be called the perimesencephalic or ambient segment. P3 is a quadrigeminal segment. It extends from the posterior aspect of midbrain or the origin of inferior temporal arteries till the carcarine fissure or the origin of terminal cortical branches, which are the parieto-occipital and calcarine arteries. And P4 represents the terminal cortical branches. PCA gives 3 types of branches: perforators, ventricular or choroidal branches, and cortical branches. One group of perforators is the mesencephalic perforators, which arise mainly from P1 and P2 to supply midbrain. These perforators can be direct perforators, which pierce the midbrain directly, and may be circumflex arteries, which travel for some distance around the midbrain before piercing the parenchyma. Circumflex arteries are divided into short and long groups. Ventricular or choroidal arteries are the posterior choroidal arteries, which are medial and lateral. Both arise from P2 segment mostly. Medial posterior choroidal artery and lateral posterior choroidal artery. Remember that anterior choroidal artery arises from the communicating segment of ICA. Cortical branches of PCA include the hippocampal artery, which is the first and most anterior cortical branch, the anterior, middle, and posterior inferior temporal arteries, parieto-occipital and calcarine arteries, and posterior pericallosal artery or splenial artery, which anastomoses with another artery with the same name, which is a terminal branch of anterior cerebral artery. Let's have a look at the lateral view of posterior cerebral artery. This is pecom artery, basilar artery, and posterior cerebral artery. Other branches of PCA include posterior thalamoperforators to thalamus, optic apparatus, and posterior limb of internal capsule. Anterior thalamoperforators arise from pecom artery. Thalamo-geniculate perforators supply geniculate bodies in addition to thalamus, posterior limb of internal capsule, and optic tract. Medial and lateral posterior choroidal arteries, posterior pericallosal or splenial artery, Parieto-occipital and calcarine arteries. External carotid artery, or ECA, is the smallest of the two terminal branches of common carotid artery. It begins at the bifurcation of common carotid artery and ends close to the neck of the mandible by dividing into two terminal branches, superficial temporal artery, or STA, and internal maxillary artery, or IMAX. Branches of external carotid artery can be grouped into the mnemonic sulfopsy, where S stands for superior thyroid artery, A stands for ascending pharyngeal artery, L for lingual artery, F for facial artery, O for occipital artery, P for posterior auricular artery, S for superficial temporal artery, and I for internal maxillary artery, or IMAX. These branches can be divided into two groups, anterior or ventral group and posterior or dorsal group. The anterior group includes superior thyroid, lingual, facial, and internal maxillary. Posterior group includes occipital, posterior auricular, ascending pharyngeal, and superficial temporal. Superior thyroid artery, which is the first ventral branch of external carotid artery, has 5 branches. Infrahyoid artery, which anastomoses with suprahyoid artery from lingual artery. Superior laryngeal artery, which pierces thyrohyoid membrane. Cricothyroid artery to cricoid cartilage and upper trachea. Glandular branch to superior pole of thyroid gland. And sternomastoid artery to sternomastoid muscle. Facial artery is one of the ventral branches of external carotid artery. It runs medial to the mandible and then lateral to the mandible and has an anterosuperior course towards the medial canthus. Facial artery has many branches, which include ascending palatine artery, tonsillar arteries, inferior mesenteric arteries, jugal trunk or trunks, middle mental artery, and submental artery, superior and inferior labial arteries, lateral nasal artery, and angular artery. Occipital artery is one of the largest posterior branches of external carotid artery, which passes between the mastoid process and the transverse process of atlas and runs upwards laterally and posteriorly. Its proximal portion is more straight and is a site for potential dangerous anastomosis with intracranial circulation, while its distal portion is more tortuous with less chance of potential anastomosis. Occipital artery has many branches, which include muscular or sternomastoid arteries. The largest and the most superior branch of these arteries is called the descending branch. Other branches include stylomastoid artery, transmastoid artery, which passes intracranially, terminal occipital arteries, and lateral meningeal artery. Superficial temporal artery, or STA, is one of the two terminal branches of external carotid artery. It's called superficial temporal artery because deep temporal arteries arise from internal maxillary artery or IMAX. STA has many branches, which include transverse facial artery, which runs inferior to zygomatic arch, zygomatico-orbital or zygomatico-temporal artery, which runs superior to zygomatic arch, posterior deep temporal artery, which may arise from IMAX, anterior auricular artery to anterior pinna, and terminal branches, which are called frontal and parietal branches. Ascending pharyngeal artery is the smallest branch of ACA, although it's a very important artery.
Dr. Sharma, we cannot hear you. I think you are speaking, but we cannot hear you.
No, I'm not speaking. This is the last video, but it suddenly stopped.
Yes.
Only 2 minutes are left now. From this video, this is the last one.
Yes.
It's external carotid system.
Exactly. It's 7:47, and the total length is 11:56.
Yeah.
Exactly. It's a very, very
And
short.
I don't know why it is stopped. I'm just trying to run it, but it's not working.
Well,
So,
I'm also having a lot of issues in streaming. I guess there is a net issue over there.
yeah. Uh, I think this is the last video. So I now I go back to my presentation.
Terminal branches, which are
Oh,
called
it starts again.
frontal branches. Ascending pharyngeal artery is the smallest branch of ACA, although it's a very important artery. Ascending pharyngeal artery has four main branches: anterior division or pharyngeal trunk, posterior division or neuromeningeal trunk, musculospinal arteries, and inferior tympanic artery. Anterior division or pharyngeal trunk gives the superior, middle, and inferior pharyngeal arteries to nasopharynx, oropharynx, and laryngopharynx. It also gives palatine branches to soft palate and tonsils, and prevertebral branches. Posterior division or neuromeningeal trunk gives the jugular artery and hypoglossal artery. Jugular artery supplies lower cranial nerves, 9th, 10th, and 11th, and hypoglossal artery supplies 12th cranial nerve. Musculospinal arteries supply paraspinal muscles in the upper cervical segment and upper spinal nerve roots, and the inferior tympanic artery passes into middle ear. Internal maxillary artery or IMAX has three segments: proximal related to the mandible, middle related to lateral pterygoid muscle, and distal, which passes into pterygopalatine fossa. IMAX has many branches which can be grouped into 6 groups. The first group is ascending and intracranial branches, which supply meninges, ear, and the neurocranium, and include deep auricular artery, anterior tympanic artery, middle meningeal artery, accessory meningeal artery. Accessory meningeal artery may arise from middle meningeal artery or from main stem of IMAX. Ascending and extracranial branches include anterior, middle, and posterior deep temporal arteries, which supply temporalis muscle. Recurrent branches are three: from proximal to distal, and from inferior to superior include pterygopalatine or pterygovaginal artery, also called pharyngeal branch, Vedian artery or artery of pterygoid canal, artery of foramen rotundum. Anterior branches include infraorbital artery, posterior superior alveolar artery, and the greater palatine artery. Terminal branch of IMAX is the sphenopalatine artery. Descending branches include buccal arteries, masseteric arteries, and the inferior alveolar or dental artery. Both anterior and descending branches supply viscerocranium, which includes face, mouth, and jaw. Again, the 6 groups of IMAX branches include ascending and intracranial branches, ascending and extracranial branches, recurrent branches, terminal branch, which is a sphenopalatine artery, anterior and descending branches.
मेरा ही तुमने presentation. So everybody can see my slides now.
Yes, we can.
Okay. So it was a lot of interruption in that, but I will post this presentation into the group. So
That that will be excellent. That will be great.
because there are only few slides, but I wanted to, explain, but I think we have wasted a lot of time in the interruption and all that. Anyhow, I try to recap and then I will post it in our group. So middle cerebral artery, these are again the cortical branches of the middle cerebral artery. Just to, you need to memorize all this, but you should know this. And again, this is AP projection of the left carotid angiogram. This is very important that whenever you see some angiographic picture, you must be knowing that which view is this and which injection is this. So this is the left AP carotid angiogram. And the segments of the middle cerebral artery, they are divided according to the anatomical landmarks. So this is the first segment, which is the M1, and this is the horizontal one. And it is very easy to memorize this. You should know that first one is always horizontal, and then this is the bifurcation, which is M1, M2 bifurcation. This is the second segment, and it is always vertical. And as I said earlier, that we have divided these segments according to these anatomical landmarks. So this is insular segment. This is insular segment. And again, the next segment is horizontal, which is opercular segment. And this is the M3 segment. And the last is M4, which is the cortical one. And here you can see these branches, and you may think that these are the branches from this opercular segment, but these are not. Actually, these are all the cortical branches. So as a beginner, it's not necessary to memorize all of the branches, but you need to memorize these segments. So the first is horizontal, and then this is the vertical, which is insular, and then the third, which is M3, is opercular, and then the last one is cortical. And I have shown the cortical branches earlier. So the next is the vertebral artery. So this is subtracted and unsubtracted. This is subtracted view, this is unsubtracted view, and here you can see that this is the tip of the catheter, and this is left vertebral AP angiogram. And this one is the lateral one. So this is the AP projection, left vertebral angiogram, and you can see that from the origin, from the left subclavian artery, from where it rises, this is the V1, and then it enters into the foramen transversarium of C6 vertebra, which marks the beginning of the V2 segment. And here it goes, and then this is the V3 segment, and then the intradural component, which is the V4. So here it pierces the dura at the level of C2, and then at the level of C1, and then it becomes intradural. So basically, this is the picture I wanted to show. And again, this is AP and this is lateral projection. And this is right vertebral AP and lateral projection. This is on the right side. So here we cannot see the this blue part. Blue part is it's the bit of the V2. V2, which is from the C6 to the C2 foramen transversarium. And then this part is actually the V3, and this part. And this is intradural part. which is the V4 part. And here you cannot see, but we can imagine that this is the part which appears to be bit constricted, that it becomes intradural. And you can imagine that the left vertebral artery coming from this side, it unites here on the right vertebral artery and it becomes the basilar. This purple part is the basilar artery, and here the another vertebral artery, the left one, joins here. So from intradural component, which is the V4 segment, we have only one branch, which is in the green color. It is best visualized here in the lateral projection. So which branch is this? This is pica. Pica is the only branch which arises from the V4 segment. So you can imagine that we have cerebellum, we have medulla here, and you can imagine the branches by visualizing the medulla here. So it's all the 5 branches of the pica, and this is the cortical one. So the next branch after the pica, here in the blue part, this is ica. So this is the basilar artery. From the basilar, we have anterior and inferior cerebral artery ica, or sometimes we have internal acoustic artery, which may arise directly from the basilar or from the ica. So this is the classical right vertebral angiogram. Normally, the angiograms are not classical like this. They have sometimes the single trunk of the ica and the pica. Sometimes they have ica rising from here, sometimes from here. But this is the classical picture. So here we have many pontine perforators, which are the short and the long circumflex, as you have seen earlier in the video. But I'm just focusing not on the perforators, but the main arteries. So the last artery, which is arising from this basilar before it ends up into the, or bifurcates into the 2 posterior cerebral arteries, is the superior cerebellar artery. So it's the left one, it's the right one. And here you can see that this is the posterior cerebellar artery on the left side, but on the right side, we don't have any posterior cerebellar artery. So where is that? This is a variant in which one of the posterior cerebellar artery is atretic, and all the supply of this area is coming from the interior circulation through posterior communicating artery, and this variant is called the fetal type of the PCA. It's a bit premature to talk about these variants, but nevertheless, I'm just explaining that why we don't have the PCA on the right side. So this is the posterior cerebellar artery, and then these are the 4 segments of the posterior cerebellar artery. And this is the lateral projection. You can see this is anterior medullary, lateral medullary, and this is other medullary and the cortical 5 branches of the pica. So, so this is an angiogram. I have taken this picture from the same video which we were, watching previously. So you can visualize that these are the orbits here, and this is the nasal part is here, and you can visualize that this is the AP projection. So, and this is the left vertebral angiogram. And if we can imagine that right vertebral angiogram coming from this side, it unites here, and then we can have this basilar. So this is again the classical one. You can see that from the V4 segment of the left vertebral artery, we have the pica, and then this is the classical left and right ica, and then superior cerebellar arteries before the termination into the 2 posterior cerebellar arteries. These are 2 superior cerebellar arteries. Now, superior cerebellar arteries are infratentorial, and posterior cerebellar arteries are supratentorial. So this is a bit of the difference. And we have the different branches of the you can see the inner one is right of the temporaries. These small, but the
Dr. Saima, we are having some interruptions in your sound. Dr. Saima is not in the Zoom anymore. We are waiting for her to join back. There are a couple of things that, okay, when Dr. Saima comes back, we discuss. I would certainly recommend all the juniors here to, to visit and to read from the radiopedia.org and the neuroangio.org, because these are the two websites that you should go through, especially before our next lecture, so that you can have an idea. And there's also one thing that actually hopped in the chat box that I need to tell you. I believe we have got juniors as well in the attendees. Segments is a different thing from branches. Segments, like the IC segment somebody was talking about, segments are different and branches are different. Okay, so just a moment, Dr. Uh, Hello, everyone. I believe that Dr. Simon might not be able to join us again because there is some critical issues in our internet connection. So we probably would, have this discussion pending for the next session. I hope that you will all be there next time as well. So, um, no, the meeting is still on. Just a moment. Dr. Simon was here, and probably because we are having some internet connectivity issues, that's why she is not able to, join the meeting again. So we will hold this discussion, the questions that are in the chat box, and there are a couple of things that we might need to discuss and clarify. We will hold this till the next session on 6th of October, inshallah. So please stay tuned, and Dr. Simon will be posting the stuff in the WhatsApp group, hopefully, inshallah. And also, do you have my YouTube link? I will also share it in the group, in the NASSIC group, so that you can all subscribe to it and just access all the videos there. The whole lecture is being recording on my YouTube channel, so you can go through it and just see it. And Dr. Simon will also share whatever she, all the slides in the video that she's got. So again, thank you very much for joining in, and we are holding on to your questions and the discussion that we had in our mind towards the next session. But by that time, I would like to recommend you to go through the radiopedia.org and the NeuroAngio website by Maxim Shapiro. And these are two very good websites that you will that will be very good for you to sometimes when people go through them for like for the juniors, they go through them for and just one reading, you might be finding them a little bit confusing, but you just have to go through them again and again and watch the video and the lecture so that you can have a better insight. So again, thank you very much for joining in, everybody, and we hope to see you again on 6th of October, inshallah. So have a wonderful day ahead. Bye bye.